morning, ladies and gentlemen. As you all know, successful healthcare and risk communication can happen only when the unique characteristics of patients are deeply appreciated, when they are perfectly matched with the intimate reality of individuals far beyond the reach of epidemiology. Risk communication must take account of the risks of medicines and disease and the universe of risk that a patient brings with her, including a metacognitive grasp of the risks posed by the physician and the system. Three topics pose specific challenges: the risks of conditions and medicines of unique importance to women, systemic institutional obstacles to equal and effective treatment that are themselves risks to women's health, and the contextual risks of women's lives that profoundly affect their access to healthcare and the benefits they can hope to get from it. Although women live longer than men in almost everywhere, they suffer from more illnesses and disabilities through their lives: reproductive health, cancer, heart disease, chronic pain, depression, visual impairment, osteoarthritis, dementia, and other diseases of old age are major issues. In coronary heart disease, women receive less effective treatment and have poorer outcomes than men. In conditions unique to women, such as pregnancy and menopause, there are vast disparities in access, treatment, and outcomes within nations and across the world. Chronic pelvic pain has long been neglected, even disparaged. Clandestine abortions represent an enormous threat. Many of the treatments and tests for women, about which women have multiple idiosyncratic preferences and priorities, are themselves complex, problematic, or risky. Screening for breast cancer, medication for epilepsy, and other procedures and conditions in pregnancy, menopausal hormone therapy, contraception among them. Healthcare systems, institutions, and priorities are largely designed and managed by men. Many women are subject to the arbitrary rule of male authority. Recruitment of women in clinical trials, neglect of issues of importance to women in research, such as endometriosis and menopause, differential and discriminatory treatment, excess opioid treatment for pain, for example, oppressive male behavior and neglect of compassionate care all exhibit systemic bias, a real danger for women. Data and information are not always disaggregated by sex. Millions of women have little or no access to healthcare or are inhibited or prevented from accessing it. Women in ethnic and sexual minorities, even within affluent societies, endure higher risks of pregnancy-related complications and deaths than white women. Rural women, higher risks than urban women. Risk communication for women can achieve its aims only under three major conditions. First, when women have easy access to the best information, tailored precisely to their preferences and habits, or ideally, to local, well-informed health workers, preferably women. Second, when researchers and health workers act on the belief that the needs, preferences, and priorities of women are urgent and important and quite different from those of men, and may be ill-served by traditional epidemiology, risk communication, package inserts, and treatment guidelines. Third, when the fact that women live their lives in complex, often oppressive and risky conditions is integral to diagnostic insight, that women's health and welfare, their potential for adherence and self-management, the risk of treatment regret, are intimately influenced by political, social, economic, systemic, spiritual, and psychological operators that are additional major risk factors that require recognition and management. Without knowledge and wisdom in the richness, complexity, and risks of women's lives, of this individual woman's life, even good data is a poor servant, and statistical benefits and harms of medicines unreliable guides. The authentic narratives of women's lives are the essential foundation for good risk communication.